So good morning, everyone. I just want to remember, this is my new thing I'm doing. If the person doing grand rounds is in your division, please come and sit in the front. So pulmonologists have to come forward, come to the front. So Happy New Year, everyone. I'm glad to see all of you back. And just a little shout out to the snow coming. So my meteorological statement today is simply, we're actually going to have snow. We're going to be able to do some cross-country weekend, so stay safe and enjoy the snow. So I'm very honored today to be able to present our Grand Round speaker, who is Dr. Milan K. Hahn, MD, MS. She's a professor of internal medicine at the Division of Pulmonary and Critical Care Medicine at University of Michigan Healthcare System, and she's also the director of the Michigan Airways Program. So Dr. Hahn did her medical school career at University of Washington School of Medicine, and then she came east, where she's been since that time, and she came to the University of Michigan Health System, where she did her internship, her residency, and her fellowship in pulmonary and critical care medicine. While at Michigan, she also got a master's, and that master's was in clinical research design and statistical analysis at the University of Michigan as well. She sits on numerous important professional societies, including the American Thoracic Society and the European Respiratory Society. She's an assistant editor for the Journal of the American Journal of Respiratory and Critical Care Medicine, and serves on several editorial boards and for several journals, including Thorax and Lancet Respiratory Medicine. She's a scientific advisory committee member to the COPD Foundation and the American Lung Association. When I was perusing her CV, I have to say, she is an incredibly distinguished researcher in her area of COPD. She has 23 active grants, over 100 invited presentations, and over 240 peer-reviewed articles. It's just incredibly impressive. Part of those grants include being the PI of the University of Michigan COPD gene study, as well as the Spiromic study, which are two large National Heart, Lung, and Blood Institute-funded COPD cohort studies, as well as the American Lung Association Airways Clinical Research Centers Network. She also serves on the Global Obstructive Lung Disease Scientific Committee that develops internationally recognized management strategies for COPD, and we all know that COPD is something that we are focusing on very greatly. When I looked through her honors go from high school all the way to this past year. In 2019, she received the Dean's Clinical Health Services Research Award. And in 2019, she was also inducted as a fellow of the American Respiratory Society. And her first award that she has down, that I thought I'd do a shout out for, because she's been a superstar her whole life, is in 1991, she was valedictorian at Skyline High School in Idaho Falls, Idaho. And so with that, we're very thankful to have you here today. Dr. Hahn, please come up and give grand rounds.
All right. Well, I'll see if I can live up to my CV then, huh? Good morning. This is actually my first opportunity to come to Madison. I live in Ann Arbor. It's obviously not very far, but somehow I just haven't made it up. It's lovely, and everyone's been super welcoming, so thank you. So I realize I have somewhat of an ambitious talk title here, Unraveling the Origins of COPD, but when I say that, I really mean it in every sense of the word, even how we came to even describe this disease that I think we all know when we see it as COPD, and whether the definitions that we've created for ourselves, whether they're still serving us well, or are they still serving our patients well. So here are my relevant conflicts of interest. So I actually had the good fortune this past year of giving a talk at the American Thoracic Society for the NHLBI. They were celebrating their 50th anniversary. And so I got to give this talk on the history of COPD. And so I thought it would be fun to open with this slide. So going back roughly 200 years, and at that point, I think many diagnoses, our understanding of pathology really came post-mortem. And so this is from Linac's Treatise on Diseases of the Chest, And he notes that in opening the chest, it is not unusual to find that lungs do not collapse, but they fill up the cavity completely on each side of the heart. So sort of our first recognition that there are individuals who have air trapping, possibly due to emphysema. The bronchus of the trachea are often at the same time a good deal filled with mucus fluid, so kind of our chronic bronchitis. I would like to say that we have advanced a lot in the past 200 years, but I think you will find that much of our thinking is still very much the same. So it was really in the early 50s at the Seebeguest Symposium when they really got down and started to say, okay, we know we're seeing these patients with emphysema, we know we're seeing these patients that have chronic bronchitis. The first time the word COPD was used was actually in 1965 at an Aspen Lung Conference. But physiology really did not become part of the definition until 1987, when the American Thoracic Society put out its first document on COPD. And then it was in 1995, I apologize that this is small, but I'm pretty sure everyone has seen this Venn diagram of asthma, emphysema, chronic bronchitis, and sort of the complete umbrella term that we currently recognize as COPD. For our current definitions, as defined currently by the Gold Committee, airflow obstruction as defined by spirometry is still absolutely vital to our understanding of defining the disease and staging people, putting them into buckets, developing treatments, etc. And so one of the things that I want to talk to you about a little bit today are where are we at now, and what are some of the challenges, particularly around early disease with respect both to detection as well as understanding patients who don't completely fit our current definitions. So I think, as I mentioned, there are really two issues that I want to talk about today. The first is the undiagnosed patients that really probably should be treated. I'm going to share with you some data today talking about how many of these patients are and why I actually think it's important that we do a better job of finding them. And then there's this kind of fuzzy area of patients that don't currently meet our diagnostic criteria, but we're learning more and more about these patients and whether they should be given a name, whether they should be treated. Do we need to rethink how we define this and approach this disease? So, but why do I think that is so important? Currently in COPD, we have no, at least FDA-recognized disease-modifying therapies. For other diseases like cancer, we know we can extend life expectancy by so many months if we give drug X. For rheumatoid arthritis, we know that if we give disease-modifying therapies, that we will have fewer erosions, less measurable joint damage, etc. For COPD, while there is some accumulating evidence, we don't really have strongly recognized even disease-modifying therapies. And the idea that I would like to offer to you today is that the reason we don't have disease-modifying therapies is because we haven't actually been studying disease at a point where it probably can be modified. So most of the clinical trials that have been done in COPD focus on GOLD, say 3, 4, so fairly severe airflow obstruction. And why is it that they do that? Well, those are most of the patients that we have on hand for clinical trials. So unless we do a better job of getting a handle on early detection and characterizing these patients, I really think we're going to continue to struggle with developing disease-modifying therapies. And again, one of the reasons why I think it matters is that if we aren't catching people early enough, they may have so much lung destruction that even if we have therapies that are effective, we're not going to be able to measure it if we continue to study severe disease. So it ends up being a bit of a vicious cycle. So what about these undiagnosed patients? We know there's roughly 30 million individuals in the US who have COPD, and roughly half are undiagnosed. Even crazier, of the patients who carry a diagnosis of COPD, only a third have actually had appropriate diagnostic testing with spirometry. So we have a lot of undiagnosed and probably misdiagnosed patients out there. So why is that? a couple of years ago, I had the opportunity to work with Lancet Respiratory Medicine to do sort of a 360 perspective on healthcare for COPD in the U.S. What's right, what's wrong, kind of just a full look, physicians, patients, caregivers, et cetera. And when we drilled down into the primary care group and into patients and how they're presenting and why we're missing the diagnosis, we recognized a couple of different barriers that are challenges that really would need to be overcome. We know that care providers now have an increasingly large list of things that they have to do in the office, not just COPD. So often there are time limitations. One of the tricky things about COPD is that patients will naturally continue to cut back on their activity levels to avoid dyspnea. And so if you ask a patient, are you short of breath, you will most likely get an answer, no, I'm fine. In addition to that, patients tend to chalk up their symptoms to, oh, I'm getting older, oh, I smoke, I'm just not even going to bring it up. So a lot of times, unfortunately, it doesn't surface to the forefront of a conversation with a primary care provider. And then, you know, the less that you use spirometry, the less you're going to feel comfortable with interpreting it and ordering it. So these all remain challenges on the physician side of things. But at the same time, we haven't done a good job of educating the general public. Our patients aren't really aware of the signs and symptoms of the disease. They may not know what COPD is, and they may not know that they need to push their doctor for appropriate testing. Unfortunately, as I mentioned in the previous slide, the fact that we don't have any FDA-recognized disease-modifying therapies has, I think, further compounded sort of a therapeutic nihilism within many of our primary care providers, such that they don't feel they can screw it up. There's nothing that would make a difference if I treat them now or later, and if they're not complaining, why bother? And I would argue today that we need to start paying attention. COPD is somewhere between third and fourth leading cause of death worldwide, and I think that's only going to go up. Another challenge that we have, I guess, for people in my field is that this document came out in 2016. So the U.S. Preventive Services Task Force had issued a prior document in 2008, and they're relatively similar, and they do not find evidence for screening COPD in asymptomatic persons. And while I do not disagree with that statement, unfortunately, I think the takeaway point for many physicians is, oh, well, I don't even need to bother then with COPD, and it pushes it further down on the list of things that come to the forefront of our attention. So what is the problem with this? Well, I think it's important to note that they said asymptomatic, and unless we're really querying patients appropriately, we may assume a patient's asymptomatic when they really may not be so. The report also points to lack of evidence, not negative evidence. We really don't have any good early intervention studies to show whether it would actually make a difference if we picked patients up earlier. So this is clearly an important area, but an understudied area. And the general consensus is that case finding probably makes a lot of sense, but we don't really even have any good, well-developed case finding approaches. We have a couple of questionnaires that people have put together based on questions that sort of make sense. Do you smoke? Are you short of breath? Well, yeah, maybe that's the patient who should be screened. But I would argue that those patients that are sort of out there simmering, undiagnosed, actually really matter, and they are a burden on the healthcare system, and these patients, their lives truly are being impacted. So when we look at the burden of undiagnosed disease, this is data from N. Haynes that David Menino published back, my gosh, almost 20 years ago now, but suggesting that we still have a significant number of patients with airflow obstruction who are undiagnosed. It goes up with age. This is a really interesting study from CanCold. CanCold was a Canadian general population-based study where they went in, they did pulmonary function tests, CT scans, et cetera. And they looked at exacerbation-like events in patients with and without a diagnosis. They defined exacerbations either based on healthcare utilization or just an increase in symptoms, regardless of how you look at it. Yes, there are slightly fewer events in the undiagnosed than the diagnosed, but what's really interesting is that you even have patients who are undiagnosed with as severe as GOLD 2 or worse disease, where 20 to almost 30% of those patients are having exacerbations. So those are all potential opportunities to help those patients feel better. and to help reduce the burden of these events. Interestingly, this is also an analysis from NHANES data done by a mentee of mine a few years ago. And when you look at the long-term mortality rates for patients without lung disease, it's up here in the green, but what's fascinating to me is that for undiagnosed obstructive lung disease, the curves are nearly identical to those with diagnosed obstructive lung disease. So just like those who are diagnosed, these patients are having events, they're dying, and arguably worthy of our attention. So a couple of years ago, working with several other colleagues, both in pulmonary and in critical care, we developed a new case finding tool for COPD, but we did it in a very different way than has previously been done, as opposed to just coming up with a list of questions that we think was good. We did that too, but we searched the literature for relevant questions, and then we had focus groups with patients, tested items against patients who were newly diagnosed, patients who do not have obstructive lung disease, and we came up with a questionnaire that we call CAPTURE. The questionnaire is actually somewhat unique in that it's designed not just to find COPD, it's designed to find symptomatic COPD in patients who are at increased risk for exacerbation, so the patients that you would most likely treat. And we developed it to be done in conjunction with peak expiratory flow. And we got the best sensitivity and specificity when we established a score of 5 or 6 with the questionnaire, or as low as 2 if they had abnormal peak expiratory flow. And then the argument is that those are the patients that we go on to have spirometry. This is the instrument, and what is actually the single most interesting thing to me about this instrument is the one question that's not there. The one question that's not there is, do you smoke, or have you ever smoked? Now, we know that roughly 20 to 25% of patients who have COPD actually do not smoke. We did have smoking items in the test item set, but we ended up not including them, in part because we want this to be able to capture everybody. The smoking question, interestingly, did not really add that much to the diagnostic capabilities of the test. And we were also a little bit afraid that if we had a lot of questions in there about smoking, it might turn people off from even answering the questionnaire in the first place. So we have questions about, have you been exposed to a dusty job, secondhand smoke? Did your breathing change with changes in the seasons, weather, air quality? Do you get short of breath with activity? Do you tire easily? Have you missed work due to a respiratory infection? And then we combine that with the peak flow. So fortunately, we have gotten funds from NHLBI to actually go ahead and test the questionnaire in real life settings in primary care offices. This is something I was unfamiliar with, but if there's anyone from family practice out there, you will be more familiar with this than I, but we are validating the questionnaire through practice-based research networks throughout the US, 5,000 primary care-based patients in rural areas, urban areas. We've got LA, we've got South Carolina, we've got Colorado. So the study is about half recruited, and we'll be looking not just at the sensitivity and specificity of the questionnaire, but also whether it impacts outcomes. And we're really hoping to have some information to now inform things like the US Preventive Services Task Force. So I mentioned that there are potentially 2 areas then that I think are concerning. It's not just the undiagnosed, but this is, to me, and where I've spent probably most of my energies, it's the patients that do not currently fit diagnostic criteria. What do we do with them? And I will tell you that for those of us that this is kind of all we do, this is our little world, we are really at a crossroads right now. The NIH has a couple of large cohort studies where they've done a lot of characterizations. These include both the COPD gene and the spiromics cohorts, which include CT scans, PFTs, questionnaires, et cetera. And COPD gene has gone ahead and actually just issued their own new diagnostic classification system for COPD. So it's been a little bit tricky for me because I sit on COPD gene and I also sit on GOLD. And the COPD gene new classification system includes things like getting CT scans. And when I put my GOLD hat on, we're also worried about developing countries who can barely get spirometry, much less the fancy CT scans that we have here in the developed world. So we have all this information. We know we need to be moving forward with it, but how we move forward exactly is right now really kind of, again, we're really at a crossroads. So the funny thing is that we've actually come full circle. So GOLD was first established in 2001, and actually initially it was actually a collaboration not only with academia but with NHLBI and with industry back in 2001. And the one of the very earliest reports actually included what is now defunct, but it had this GOLD stage 0. Funny thing is that that term has not actually died, even though this is the only time it showed up, because it's actually been clinically useful. But the GOLD stage 0 was a patient who did not have airflow obstruction, but they did have symptoms. They had cough, they had phlegm, they had what we'll call chronic mucus hypersecretion. You can also call it chronic bronchitis. But they defined this at-risk group because that was a group that you might want to pay more attention to with respect to vaccinations, with respect to smoking cessation. And it was sort of, I remember when, oh my gosh, in the early 2000s when I first started giving talks for COPD, this was the slide. This is what I showed every single time. But then in 2006, all of a sudden, GOLD 0 got taken away, gone. And why is that? Well, between publishing the prior document in 2006, some new information came out. So at the time, there was this study called the Copenhagen City Heart Study. And it was a population-based study. They looked at things like smoking and symptoms, and they measured who got airflow obstruction at 5 years and at 15 years. And in patients that had GOLD 0, so they were symptomatic, they saw COPD develop in 13% and 20% respectively at 5 and 15 years. And if you look at the statistical relationships, there was a relationship between symptoms and accelerated lung function decline that was more prominent in men than it was in women. The problem is that if you look at the rest of the patient population, the numbers aren't that much different. 12 and 19% of those who were asymptomatic also got airflow obstruction. And it turns out that of the total number of patients that got airflow obstruction, this actually represented the much larger chunk than the patients who were symptomatic. So because of this, GOLD really didn't know what to do with this anymore, and so they weren't sure that the concept of GOLD 0 was clinically useful, and so they went ahead and decided to just go ahead and drop it from the document. The problem, and that we're now hitting at full circle, and I know will be discussed at the GOLD meeting this spring, is that we now realize that GOLD 0 does not equal no disease. So we are coming to realize that smokers who do not meet the definition for COPD may still have respiratory symptoms. They have clinical impairment, they have cough, shortness of breath, they have exacerbations, they have CT abnormalities that look just like patients with COPD in some instances. So the real question is what to do with these individuals. And I would go one step further, and in my mind I'm thinking about two separate things. One is regardless of whether these patients go on to develop airflow obstruction, they need to be recognized as an entity and probably have therapies developed. But then there's also the subset of those patients that probably are in the exact same pathogenic process timeline of developing COPD, and do we need to go in and try to figure those people out and modify the disease, try to modify the disease earlier? But how can we find those patients too? How do we separate out these patients? So some of the data for what has caused this somewhat kind of conundrum or crisis really even within the COPD community is some of the data that I mentioned was coming out of the cohort study. So this is data from COPD Gene, and when you look at these patients who do not have airflow obstruction, roughly 20% had some type of CT abnormality, whether you define that as gas trapping or emphysema. If you add airway wall thickness, over 40% had some type of abnormality. And interestingly, roughly a quarter of those patients had significant dyspnea, which was actually almost identical to the patients with GOLD 1 established disease. So there certainly are a subset of these patients who look and smell for all the world just like COPD. This is, I'm going back to CAN-COLD again, and the interesting thing here is that for these patients who do not meet criteria for COPD, not only are they having exacerbation events, but these events are actually leading to things we care about. They're missing social activities. They can't work. They're missing work for income. They can't do their housework. So it's clearly having an impact, but we currently have no therapies for these patients. They've never even really been studied in clinical trials. This is a paper that came out in the New England Journal back in 2016. This is data from the Spromics cohort. And what we found here was that if you identify this symptomatic group of patients who don't have airflow obstruction, they actually look very much like the patients who are symptomatic who have airflow obstruction. And then if you look at these people, the asymptomatic without airflow obstruction, asymptomatic with airflow obstruction, they look quite similar with respect to respiratory events, which then makes you begin to wonder what's the big difference then here between those who have airflow obstruction and those who do not. When you look at these patients on CT, here's where we do start to see some differences. We do not see much emphysema in the symptomatic individuals without airflow obstruction. What we do see here, though, is airway wall thickening, which is similar to those with symptoms and airflow obstruction. So it does seem to be, at least early on, a very airway-centered process. We even though we kind of moaned and groaned about it when we were writing the protocol for this study, we did get induced sputum in all the patients. But we're really glad we did. We ended up getting some really interesting information. And what we found was that in these patients who are symptomatic, they do have increased mucin concentrations in their sputum. And that correlates with symptoms, it correlates with respiratory exacerbations, it correlates with disease severity, but even among the patients without airflow obstruction, if we look at those who have symptoms compared to those who are not, we do see higher mucin concentrations. So this is very interesting to me because it suggests that these patients really do have a different disease biology, and potentially looking at mucin as a target might be a potential future therapeutic avenue. In the meantime, though, Prescott Woodruff and I had worked on that paper in the New England Journal of Medicine, and we went ahead and pushed this forward into a clinical trial. We are roughly at 400-something patients. We have about 150 patients left to go. It's been kind of a nail biter for a lot of reasons, but we're almost done with this study. And it's a very, very simple design. It's not particularly sophisticated from a biologic perspective. What we did, though, is we realized that somewhere between 30 and 50% of these patients that are just sort of sitting out there in primary care who actually don't have COPD are actually already on therapies for COPD by their doctors, either because it sort of made sense, what else are you going to do, and also in part because I think the assumption for many doctors is that those patients just have COPD because they're not doing spirometry anyway, so how would they know otherwise? So we realize all these patients are getting treated. We don't really have any evidence basis. Nobody's actually ever studied them. And so we're doing a very short proof of concept study where we're, for 12 weeks, giving these patients a dual bronchodilator. We chose a dual bronchodilator because we wanted to see maximum effect. This is sort of a proof of concept study. Do these patients benefit from the drugs that are already being provided to them? I don't know, but I think it'll be really interesting regardless. Even if the results are negative, then it suggests that this is still an important patient population, but we need to look elsewhere. We can't just continue to give them necessarily the drugs that we've been giving patients who have COPD. One of the interesting kind of additional pieces to this story is this data that's coming out of what they call the UK birth cohort. So in 1946, in the UK, they did this kind of random sample population and tried to get this snapshot of all births that occurred in 1 week in March in 1946. And then they followed these patients up over the last, so many years. And they did visits in the mid-20s, in the mid-30s, in the mid-40s, in the mid-50s. And what's interesting when we think about the timeline for disease development and when patients are typically diagnosed now, 50s and 60s, that actually chronic mucus hypersecretion is actually noticed as early as the visit when they came back when they were 36. And they've also then gone on to demonstrate that presence or the symptoms, the more times that they were present was associated with more rapid lung function decline, which then kind of brings us full circle back to, well, do we need to be thinking about that gold zero group? Do we need to bring them back? One of the other things that has begun to change our thinking about the disease is data that's coming out from some other cohort studies, mostly in Europe, with respect to how the disease develops and what does the life course of the disease look like. So probably everyone in this room has seen the Fletcher-Peto curve before, and this is what's taught in medical school, and this is what we all think of when we think of how one progresses. You start with good lung function in your early 20s, and if you don't do anything bad to your lungs, you lose some lung function, but you'll probably still be in a really good place when you die. But if you smoke and are exposed to bad things, then at some point the lung function declines and you develop symptoms, and then you develop disability and you die early, and it's just sort of this generally linear pathway. But this data that was published by Peter Lenga, the New England Journal in 2015, has really called into question how we think of, how we conceptualize lung function decline. And they took data from 3 separate cohorts and then looked at trajectories. And what we found was that of the patients who ultimately developed COPD, roughly half actually hit peak lung function in their mid-20s and then had more rapid decline. The other half, interestingly, never hit peak lung function at all. So something must have happened in here. And then they had sort of age-related normal rates of lung function decline. So being that I am an adult academic pulmonologist, and we're trying to think about how we can intervene, how we can modify the course of disease, it probably doesn't make a lot of sense for me to focus on this white group. Not that somebody shouldn't, but that's probably our pediatric pulmonologists, our pediatric group. For me, as an adult pulmonologist studying COPD, it makes most sense for me to try to target in on the red group. For those that are declining rapidly, how do I figure out who those patients are so we can go in and intervene? The problem is that all of the big cohort studies that I just mentioned studied patients in here. What we really need is for somebody to study patients in here. If you think about it, if you have a patient who has a cough, symptoms, maybe a little emphysema on CT, and they're 80, and those are the patients that we've been studying, that's probably not going to tell us a lot about disease mechanisms and trying to identify patients that are going to progress rapidly because they're already 80 and nothing bad happened to them and they never developed airflow obstruction. If we want to figure out and tease out the mechanisms, particularly from a biologic perspective, we've got to go much, much earlier in the pathway to try to figure out who these people are on the red line. So in thinking about kind of what I think of now as early COPD, we have to distinguish disease, sort of the first disease developing in a young individual from what I'm going to call late mild disease. And so it's this true early disease that we really need to be focusing on. But then the next question becomes, well, if we want to find these people so that we can develop and test disease-modifying therapies, how in the world are we going to find those people? Well, first it's going to involve probably some case-finding approaches like we just talked about. But then once I find these people, what characterizations do I do? Is there a biomarker? Is there a CT? What can I do to try to figure out who these people are? So in working with some of my colleagues, including my mentor, Fernando Martinez, in 2018, we decided, well, we first have to just try to put a box around these people. Who are the people that we want to study? And we decided, well, and there was tons and tons of disagreement about the age cutoff. Some people thought it should be 30, some people thought it should be 40, some people wanted to take their name off the paper if it was over 50. We kind of ended up sort of in here. I was kind of pushing for later because we don't really have any information on people really under 60 much in any of the US cohorts. But we decided we would define this group by either slightly abnormal pulmonary function testing using lower limit of normal equations as opposed to the 0.70 cutoff recommended by Gold, some type of compatible CT abnormality or evidence of accelerated decline. Now I realize that finding people like that currently is going to be very difficult outside of a clinical trial, but we thought that was potentially a place to start. Some of the reason behind why we chose some of those thresholds, in particular the 10-pack years, is again data that came from this UK birth cohort. And what they found when they were looking at where accelerated lung function could be identified, they found that 10-pack years among individuals as early as in their early 40s is where accelerated lung function decline could be detected. So it's probably sort of in this 40s to 50s range at least a minimum of 10 PEC years where we want to be targeting and starting to look for first signs of disease. So what are first signs of disease? I think, so I've talked about kind of the larger airways, chronic bronchitis and mucus production. And I think that's part of the story, but I don't think it's the whole story. We know for end-stage patients, they ultimately develop emphysema, but how does that exactly happen? So there's a lot of work that's been done by Jim Hogg's group at the University of British Columbia. This was published by he and his mentee at the time. Back in 2011, and Jim's done a ton of work he's a pathologist and he's done a ton of work to try to figure out what's going on with the small airways. And it's been his hypothesis for many years now that it is the small airways, the airways less than 2 millimeters in diameter, that are really the target of early disease. You can see from this data where they did from lung resections, they just did airway counts. And in as early as GOLD 1, you can see a significant drop off in the number of airways compared to GOLD 0. Unfortunately, we don't have normals here, so I don't know where they would sit. But you can see that at least it does appear based on this data that the airways are dropping out early. There are other data that have come out looking at CT data, and they've been trying to count the airways. And it would seem to corroborate this. He then did some additional detailed analyses of lungs in areas of emphysema, which he defines as sort of the whole size being greater than 489 micrometers in terms of a term he calls mean linear intercept. But essentially, it's how big the airways are, or the air spaces are, how big the alveoli are. So when the alveoli are still normal from a pathologic perspective, there really isn't any evidence of emphysema per se. What he found was that the number of airways was much lower than your control subjects. So while this was a cross-sectional study, it's difficult to do longitudinal tissue studies, although I did have a study section recently ask me that. We can see at least in areas without emphysema that we're also starting to see areas where the airways are being lost. So what exactly is happening to those airways, and really are they the predecessor to emphysema? So much of my research actually has been focused on imaging approaches to COPD, and I'm fortunate to have a really good imaging group at the University of Michigan that I've been working with. And they, a couple of years ago, it was really interesting. They actually developed this technique using brain MRIs because they wanted to co-register brain MRIs in time to follow tumors. But then they had this idea, well, what can we do? How can we apply that to CT scans? And our chief of thoracic radiology at the time said, well, why don't you look at the inspiratory and the expiratory CT scans at the same time? So what they do is they marry the inspiratory and the expiratory images to see exactly what happens to voxels between inspiration and expiration. And what that allows us to do is to separate what we think is healthy lung, which is green, to areas of non-emphysematous gas trapping, which we think is small airway disease, and red, which is emphysema. And what we found in the COPD gene cohort is that the patients who are GOLD 0 that have the highest amount of small airway abnormality did decline the fastest. When we look at longitudinal data, we see the yellow voxels actually turn into red voxels over time, which would really corroborate Jim Hogg's story about small airway abnormality being the early lesion in COPD. We also see, and this was 5-year follow-up data in COPD gene where we looked at baseline and follow-up CT scans. This is emphysema here on this axis and small airway abnormality. You can see that these patients early on get high in small airway abnormality, and that would appear to convert over to emphysema with time, which again would corroborate Jim Hogg's thinking. The final thing that we did and just completed this year, and I know my husband is really thankful this project is over, and I'll show you why in a minute, is that we decided we needed to validate the small airway abnormalities that we were seeing with this PRM imaging methodology. And so Jim Hogg had developed some techniques to use micro-CT. So what we did was we took lungs at the time that they were coming out for lung transplant. This was the first one we did, and my surgeon wasn't there, so you can see we have zip ties. When my surgeon's there, we have really lovely, lovely connections, but when it's me, we have zip ties. So this is my surgeon and my nurse, and for those of you who do any kind of transplant, you will know that transplants only occur in the middle of the night because the ORs and the operating room and the surgeons are all booked during the day. So all of these were 2 in the morning, where we would actually, so we had CT scans on all the patients with COPD before they went to transplant. We'd get the lungs out, we'd actually run those through the scanner again. We'd slice them, we'd core them, we'd freeze them, we would take samples out and for micro CT and send them to Jim Hogg's group. And so what did we find? We had a few gift of life control lungs, and as you can see, the airways are thin, they're open, they look healthy. From our COPD patients, you can see that the airways become thick, they become narrow, they become scarred. Here you can see kind of the 3D view. And then if we look at the count of the airways, again, they're dropping out. So this really suggests that even probably before the development of emphysema, we're starting to see airway abnormality. And we were able to correlate the in vivo CT measures with all sorts of airway things that you would care about, like number of bronchi across sectional lumen area, et cetera, wall thickening. And then the emphysema measures, not surprisingly, fell in line with things we would care about, like how much alveolar surface area there was and airspace size. So this is actually the first time we've been able to validate a small airway metric with CT. We went back in the Spromix patient population, and Mehmet Kazimir, who's doing all of the mucin analysis, actually was able to demonstrate that patients with higher amounts of small airway abnormality actually also had higher mucin abnormality. So I thought that was really interesting and helps to tie things together a bit. So what do we really think is going on? I have to tell you, I don't know for 1,000% sure, but we're just kind of digging and clawing our way through this. And me being sort of more of a clinical and translational researcher, starting sort of from the outside in, there are many people who are obviously working on this in the lab. One of the things that we suffer with, though, with COPD in particular, is that we really don't have great mouse models. And so we are trying to rely more and more heavily on human data and data that we're collecting, for instance, from bronchoscopies. So, and this comes from the document that we published in the Blue Journal a couple of years ago on early COPD, but this is sort of our conceptualized thought on this. So we know that basal cells are sort of the progenitor cells in the distal epithelium. They're self-renewing, and the thought is from some gene expression studies that there is early basal cell reprogramming, and it with smoking, and it alters the regenerative capacity of those basal cells, induces hyperplasia, and ultimately squamous metaplasia, and then loss of certain cells. At the same time, you then have excess mucus production, trapping of bacteria, and in COPD, we're also seeing less secretory IgA getting out into the airway, which also then allows more bacterial invasion. So there are likely ultimately more mechanisms going on, but right now this is sort of the thought process that we're getting at. So the bottom line, though, for me is that if we can look at things like mucin concentrations, if we can look at things like small airway abnormality on CT, these might be the hints, these might be the biomarkers that we need to try to identify these patients that potentially could benefit from early interventional trials. Sort of along the same line, some of the gene expression data that we've gotten from Spromix bronchoscopies led by Prescott Woodruff and his mentee Stephanie Christensen at the University of California, San Francisco. She has been able, so the IL-17 family has been known for a while to be related to host defense and chronic inflammation. They developed an IL-17 gene signature, and when they looked at patients in Spromix, they found that expression of this gene signature was directly related to sputum neutrophils. They also saw a relationship between the IL-17 signature and the CT small airway abnormality metric that I described that we call PRM. So IL-17 has been implicated in all sorts of pathogenic responses, including emphysema and dysbiosis. So again, some of this stuff does seem to feel like it's starting to fall into a little bit more clarity. I suspect there are other mechanisms at play. It's not just one disease, but this does seem to be starting to form a bit of a story for me. So going back to this, how can we put this all together? How can we ultimately develop disease-modifying therapies? We know we need to find these patients. We're starting to develop the mechanisms to do so. One of the reasons that I feel so strongly that this is the right way to go is that, as I mentioned, many of the COPD studies that have been done have focused on these patients. And mostly because those are the patients that we know about. Those are the ones that are seen regularly in the clinic. They're the ones that were easy to grab for clinical trials. But this is data that we published from COPD. And if you look, this again doesn't quite match up with that Fletcher-Peto curve, which kind of looked more like this. Here what we really see is much more accelerated decline, particularly even in GOLD 1, and then that kind of slows down. So if we really want to show that a therapy can slow decline in FEV1, then continuing to study patients like here that are barely declining at all, you're not going to be able to move that needle. So again, that's why I feel so strongly about needing to move us up into at a minimum milder disease. So at a minimum, people are finally starting to think about milder disease, but it's not just mild; it's also early in terms of the age component as well. That I think is truly important. But this is an intriguing study, to me, kind of a proof of concept study that was published by a Chinese group in the New England Journal back in 2017. So people may or may not remember, but the biggest study that's ever been done for tiotropium, which is a long-acting muscarinic antagonist for COPD, but the biggest study that was ever done, which was designed, it had 6,000 patients, it was designed to show whether tiotropium altered lung function decline, called the UPLIFT study, was negative. One of many, many negative studies in COPD, but it was negative. And now it clearly helps to bronchodilate, it clearly helps to make patients feel better, and it does reduce the frequency of exacerbations, but it didn't do what they were hoping it would do. It didn't alter lung function decline significantly over time. But if you look at the patients they studied, it was roughly 1/3 GOLD 2, roughly GOLD 3, and GOLD 4. When they did a subgroup analysis of the UPLIFT study, focusing just in on the GOLD 2 patients, they actually were able to show a benefit with respect to lung function decline. So interestingly, this Chinese group did sort of an investigator-initiated study, but they studied only GOLD. They kind of repeated UPLIFT, but interestingly, they had about a sixth the number of patients. They only followed these patients for 1 year. UPLIFT did, or 2 years, sorry. UPLIFT had 4. So with a much smaller number of patients and a much shorter timeline, but focusing on the GOLD 1 and 2 patients, they actually were able to show a difference with respect to lung function loss over time. So to me, it suggests that this approach really has potential, but we need to take this approach then really expand on it. So in conclusion, I guess my thoughts are we really need to do a better job of finding our undiagnosed patients, because I think that's really going to help us. If we can get these patients into the system, we can understand them, follow them, treat them, and hopefully try to sort of break what I think is a bit of a vicious cycle. We need to do a better job at identifying early symptomatic COPD, further our understanding of disease pathogenesis, and in particular really focus in on these patients with not just late mild, but true early COPD. I mentioned a lot of these people when I was giving my talk, but I'm very lucky to have a lot of great collaborators at the University of Michigan. And what's really, and I can sense that this place is very similar, but at the University of Michigan, we really have great collaborations across the board with radiology and with pathology. So I'm really lucky to have a lot of really great collaborators, not just at the University of Michigan, but also at University of British Columbia, as well as just the hundreds of investigators involved in the cohort studies that I mentioned that really have helped to kind of inform these analyses. So that is that's the end of my talk. I think I'm actually really on time, I think. So,
That was fantastic. Questions from the audience? Yes.
Probably not an easy question, but to what extent has genomics helped identify people who are at risk
yeah, no, it's a really good question. So I mentioned the COPD genes. I'm sorry, repeating the question. The question was, what do we understand about genetic risk factors for COPD and how is genomics? So I mentioned a little bit about some of the gene expression studies that have been done there, but I'm guessing you're referring maybe more to like GWAS studies. And so the COPD gene study is actually a 10,000 patient study that was established primarily to look at what the genetic risk factors are. They certainly, so the best known one many of us already know about, which is alpha-1 antitrypsin deficiency. But so I will say that for many of us working on that project, I'm not saying they haven't found genes, they have. And they have developed some genetic risk scores that I think potentially could be helpful. But what's becoming super clear is that this is a multi-gene disease with multiple genes contributing small amounts of risk, as opposed to one or two single genes that are, super high hits. Some of the first genes that they identified were, not surprisingly, associated with nicotine addiction. So those are some of the big hits that they've come up with. Then there are lots of other ones that have been associated with multitudes of different pathways that probably have, smaller contributions. But I think the bigger point, and coming back to, I think, what you were asking, is that, and this is what makes COPD so difficult to study, because there are so many genes that are contributing and likely different pathways that are more predominant in any one patient. I kind of described a story and a pathway here, but it's probably in other patients, I'm sure it's allergic inflammation and other things. So yes, there have been genes. They're most useful when combined into what I would call a genetic risk score. I don't know, for IPF, some of the genetic testing I think is becoming closer to becoming mainstream and actually going clinical. I'm not sure how close we are to doing the same thing for COPD.
In the back.
So a couple quick questions. Air pollution. So obviously smoking in some areas is going down, but air pollution is going up. And there's association with COPD development. Number two, isn't anything primary prevention in smokers like aspirin or some kind of anti-inflammatory therapeutic?
So again, I'm going to try to repeat those questions accurately. The first one was asking about occupational exposures and other risk factors, and it's an excellent point. I mentioned roughly a quarter of patients with COPD don't smoke. For better or worse, the two big US cohort studies all had smoking as a criteria because they're really trying to enrich and make sure that, because they only have so much money, that they're going to get people who are progressing, but that gives us much less information then about all these other people, to your point. Fortunately, CAN-COLD actually was a population-based study and does have some information, and they were able to demonstrate relationships between other types of exposures. Interestingly, they actually were able to show a relationship between biomass fuel exposure, smoke, and a development of COPD. And I was speaking with Juan Tan, who's one of the principal investigators, and I said, what's going on? Why do you guys have all this? I don't understand this, because I usually think about that as being a developing country issue, like, women cooking over stoves in an unventilated hut or something like this. But then she reminded me of all of the wood stoves that people have in homes, and then I thought, oh my God, I had a wood stove in the home I grew up in. So yes, you're right. It is important. And your second question was, should we be doing anti-inflammatories, for instance, in these early patients? It's a great question. It's a really great question, and it needs to be studied. Absolutely. I think we need to try to, target in on whatever we think the absolute best candidate molecule is, and then maybe try to hone in on some of these biomarkers. I've been talking with some of the some pharma studies, and right now all they want to do is look at what they already have. So I suspect we'll be seeing some early intervention studies with inhaled steroids, and that's great. But I would be even more excited to see stuff that's even earlier in their therapeutic pipelines tested in this patient population. That's a really great point.
Any other questions? Nizar?
So thank you very, very much for an outstanding grand round. For the clinicians that are treating patients based on symptoms, they're treating them when they don't meet the criteria. What do you suggest they do when they do meet the criteria but they have no symptoms or minimal symptoms? They meet the criteria with an FEV1, they have airway obstruction, but they have a minimal symptoms.
That's a really good question. So I am probably not pushing those patients really hard right now, but I am tracking them closely. There is a little bit of data, and I did show it, that early introduction of tiotropium might help to slow lung function decline. There is some thought that potentially even ICS might be helpful, so we don't know for sure. But I am probably watching, and if they stay relatively stable, that's one thing, but if I do start to notice decline, I probably would initiate some kind of therapy earlier.
Thank you very much. Anyone else?
Thank you.
Please come forward.